No, so Bubbling, he was from the St. Paul schools,
Schools. Oh,
and
okay.
he was one of the other partners.
Mm.
Jasmine Grika from
Hey, this is Carol Bell. I'm here. You guys there?
We can hear you. Can you hear us?
Yeah, I hear you. All right.
Yep. Hang out, people, until we get started. We'll get started in about 5 minutes here. Thanks for joining us.
Okay.
I'm gonna mute
Sure.
us.
So,
Oh, go ahead.
yep.
Okay. Hi, Lacey. Okay. I'm gonna mute us for a little.
Okay, we are still waiting to start. We'll start in about 4 or 5 minutes. So stick with us and we'll get started soon. Thank you. All right. Good afternoon. Welcome to the Wayside Women's Services Echo. And we're so glad that all of you are here. We're going to start with introductions. And as I call your name or your number, depending on what I can see, if you would just unmute yourself and give us a quick introduction. One of the best parts about this technology is that in many cases we can see each other and we're building community even if we can't be together. So let's start with Jody. I know I can't see you, Jody, but Jody Evanson. Could you introduce yourself, please?
You may need to unmute yourself in the bottom left corner of your screen, or Lucia will do it for you. So you're unmuted, Jody. Do you want us to go ahead?
Yeah, I'm Jody Evenson. What did you want me to say? I was out of the room.
Where you're working or where you're calling from, that would be great.
I'm calling from Mora, and currently I am not working, but I'm looking at starting a recovery coach program up here.
Wonderful. Welcome. Let's go to Kate B.
There you go. Hi.
Hi.
I work with State Avenues, and I am the outreach coordinator in Mendel County, Minnesota.
Okay, Kate, you're coming through kind of garbled, so I'm wondering if you wouldn't mind. That's all right. If you can hear me, that's the most important thing, because then you'll be able to hear Jessie. But if you couldn't, if you wouldn't mind putting in the chat box your name and location again, then we'll make sure we get it. Let's go on to S. Birch. Do you want to unmute yourself and introduce yourself? Let us know where you're from. Hello.
Hi, yes, my name is Shaola Birch, and I am with Community Health Services. I'm the Community Awareness Domestic Violence Advocate.
Wonderful. Welcome. So glad you can be with us. Now we're going to go to Tony, but Tony, if you're not able to respond, you just tell me.
Driving, maybe.
Looks like you're stopped. Okay, I'm not going to put, oh, he's pushing buttons. Tony, go ahead. All right.
You might not be able to hear.
Tony, that's fine. Just be safe. Let's go on to Andrea. Andrea, could you please introduce yourself?
Hi, I'm Andrea Rowland. I'm the mental health manager here at Wayside.
Wonderful. Welcome.
Thank you.
And Lacey, could you introduce yourself?
Yeah, I'm Lacey. I'm the family service counselor at the Family Treatment Center at Wayside.
Wonderful. Welcome. And is it April? April, could you introduce yourself, please?
There you go, April.
Go ahead. Welcome, April. I'm going to keep moving.
She
Paul?
might not have a speaker yet.
Yep. Paul, would you like to introduce yourself?
Oh, hey, it's Natalie Paulbeck.
Oh, thank you.
Yeah, no, I get call a lot, to be honest. That's funny. Natalie Paulbeck, I am a guardian ad litem out of Washington County. I'm officed in Stillwater.
Wonderful. Welcome. Christina, would you like to introduce yourself? You're unmuted, so you can go ahead.
She might not have a mic either.
That's fine. Okay,
She's from Wayside, so is April.
Okay, wonderful. And then someone is on the phone at a 612-977 number. Would you like to introduce yourself?
Hello?
Go ahead.
Hello? Hi,
Yes.
yes, I'm Bethany. I'm just working at Tuggery Recovery Center here in Minneapolis location.
Great, welcome.
Welcome. And then
Thank you.
yeah. And finally, we have someone at 612-516 number.
That might be Carol Bell from Wayside. She called it. on her
Okay.
phone. How about
Well,
Jamie?
if that, oh, I didn't see the Jamie one.
Although she might not be connected by audio yet.
Can you hear me?
I can.
Can you hear me?
Yes,
All right.
Carol.
Hi, this is Carol Bell. I'm an RN, and I'm on call for both facilities for Wayside Women's and Wayside Families.
Wonderful. Welcome. And I think
Yeah.
And then the last person would be Jamie. Jamie, could you introduce yourself? Okay, that's fine. We're just glad you're here. And anyone who had any difficulty checking in, please be sure to write something in the chat so we know you're here. You'll get the evaluation form and then a follow-up with your continuing education certificate. So today's topic is co-occurring disorders, co-occurring PTSD and substance use disorder. And our presenter is Jessie Everts. And then we'll have a case presented by Andrea Rowland. And I will leave some time for questions. And please just follow along in the PowerPoints. When we send out the evaluation, we'll also send out a PDF of the PowerPoint. So don't worry about trying to write everything down. You'll get the information. And then we'll close out by 1 o'clock. I'm going to turn things over to Jessie.
Thank you. So most of you know me. I'm Jessie Everts. I am the Senior Director of Research and Innovation here at Wayside. And we're happy to have all of you. Whether you know it or not, you're getting some co-occurring training hours, which all of us employed in 245G programs need. So I hope that you're excited about that. You'll get an hour and a continuing education unit. So if you fill out the evaluation that Lucia will send afterward, you'll get both of those things recorded. So we're going to talk about co-occurring PTSD and substance use disorders today. PTSD is post-traumatic stress disorder. In 2 weeks, Rebecca will remind us of this at the end, we're going to do anxiety disorders and substance use disorders. So we're talking specifically today about PTSD, and we'll have a chance to talk about anxiety disorders at the next echo. So I hope you'll join us for that too. So I'm going to try to go kind of quickly through my information. There will be time for questions at the end. I really want to make sure we get to our case study, case presentation at the end too, so that you can hear a little bit about what a client with trauma looks like and what the treatment for that trauma might look like. So we'll get through that. So first off, what is trauma? I think we all have a general sense of what it is, and here are some of the definitions of trauma. Psychologically distressing event that's outside the range of usual human experience and involving a sense of intense fear and helplessness. A sudden or unexpected experience that creates a lasting psychological impact. And this is the diagnostic definition of trauma, is an event that makes a person feel scared and helpless. That feeling of unpredictability and fear is really what marks trauma. So here's some statistics on the prevalence of trauma. 60% of adults report experiencing abuse or other difficult family circumstances during childhood. 26% of children in the US will witness or experience a traumatic event before they turn 4. And that statistic keeps rising. Last time I did this presentation, it was 25%. We're going up percent by percent. 1 in 5 children witnessed violence in their family or the neighborhood during the previous year. And in 1 year, 39% of children between the ages of 12 and 17 reported witnessing violence. 17% reported being a victim of physical assault. 8% reported being the victim of sexual assault. More than 60% of youth under age 17 have been exposed to some crime, violence, and abuse, either directly or indirectly. So it's rising. Trauma is prevalent and it's rising. And I think there's also some new studies coming out saying that we're all being exposed to more trauma with the proliferation of social media and news stories that we have on our phones, where we have access to traumatic events in a way that we never have before. So a lot of us are being exposed to traumatic stories, and those stories can be really triggering for people who have trauma. So we're the reasons we're talking about this are because it's widespread. So the effects of trauma are these. People who have experienced trauma are 15 times more likely to attempt suicide than people who have not. 4 times more likely to become an alcoholic or have an alcohol use disorder. 4 times more likely to develop a sexually transmitted disease. 4 times more likely to inject drugs. 3 times more likely to use antidepressant medications. 3 times more likely to be absent from work. 3 times more likely to experience depression or have serious job problems. 2.5 times more likely to smoke cigarettes and tobacco, 2 times more likely to develop a chronic disease like COPD or to have a financial problem. So especially when untreated, there's a lot of repercussions and issues that can grow out of trauma. Here's kind of a list of general types of trauma, and traumatic loss is another form of trauma where it may not be an event, it may just be a loss in your life. Physical and sexual abuse are usually the things that we hear most about because they are events or sort of distinct traumatic events, whereas some of the rest of these are more ongoing or chronic. Death or loss of a loved one, domestic violence in families, witnessing police activity or having a relative incarcerated, automobile accidents, other serious accidents, out-of-home placement or termination of parental rights is one that we see a lot as a traumatic event for both children and parents. Homelessness, high mobility, having an unstable living environment are all types of trauma. Life-threatening health situations or painful medical procedures, natural disasters, terrorism, refugee and war zone trauma, life-threatening illnesses or injuries of a caregiver for a child, witnessing or experiencing community violence, and significant prolonged bullying either in childhood or adulthood. So in that list, you saw there were some things that are acute trauma. It's a single event that may be forgotten by the conscious mind, meaning you may not have a actual memory of what happened, or you may have really vivid memories. And we'll talk a little bit about the brain science behind trauma and where that gets sort of stuck in the brain. Sometimes you have a conscious memory and sometimes you don't of that acute trauma situation. Chronic trauma is longer term, and it could be a repeated sort of incident or a repeated situation that you're living in. Might be ambiguous and not have a distinct beginning or end. Something like community violence or living in homelessness or high mobility is something like that, where it's sort of an ambiguous trauma. There's not a distinct start or end to it. Ambiguous loss, having maybe a parental figure absent from your life and not having an event that caused that. Things like that are chronic trauma. And what happens as coming out of trauma depends a lot on the frequency of the trauma, intensity of it, the duration of it, how long it lasted, and the timing of it in your development. If you have chronic trauma during early childhood, it can have really pervasive and damaging effects more than just an isolated traumatic event during adulthood because of how your brain's developing and what areas of the brain that might impact. So I love to show brains, you guys. Here are some of my brain pictures. I like to talk a little bit about what happens in the brain as a result of trauma, because I think it's helpful to think about in treating trauma, that we're treating brains that have been traumatized, and that helps me understand it a little bit better. So on the left side here, you can see the outside of the brain, those lobes of the brain. What the limbic system is what's impacted in trauma, and that's inside in the middle of the brain, which is on the right side there. So that's inside the brain, kind of that deeper, more primitive part of the brain that's emotion focused and memory focused. And this next slide shows more about what each of the areas in the limbic system does. And I want to just highlight what happens in trauma is that several of these systems start to either overreact or underreact. So you can see that frontal lobe part of the brain, that's the intellectual part of the brain, the thinking part of the brain, that starts to underact after a traumatic event or chronic trauma, that you stop sort of rationalizing what happened and your attention and your memory is drawn to the emotional limbic part of that brain. So you might not be able to make sense of what happened, or you might not even be able to remember exactly what happened or have a conscious sense of it. It might just be stored as emotions and the re-experiencing of that trauma. So if you've been through trauma, you have an underactive self-regulation center. That's that cingulate cortex that's on there, the anterior cingulate gyrus. It has to do with mood. It also has to do with self-regulation and being able to sort of control your mood or control your emotions or monitor your emotions. So that starts to underact. You're not able to regulate as well after a traumatic experience. You also have a dysregulated interoception center. That's that caudate nucleus and the insula caudate nucleus. That's kind of about your self-reflection and thinking about what has happened to you and events in your life. It's kind of that automatic or default thinking patterns, and that's really impacted or dysregulated after trauma, that you start having maybe dysregulated sense of yourself and sense of your abilities, and that maybe you deserved what happened. Those kinds of thoughts are really common in that area of the brain after a traumatic event. You tend to have an underactive memory center in the hippocampus, that area of your brain that is in charge of your memories and emotion. It starts to kind of underact, meaning it's not really in touch with the reality of the memory that you're having. You might be having a distorted memory of something that happened, or generalizing based on a memory that's where people often say, well, I start to feel scared around anybody who looked like that person who was my attacker, not just that person. So your memories become more generalized and a little bit more distorted and less based in reality. And then the amygdala, that's that fear center of the brain, and that starts to overact after a traumatic event. Often you're on high alert, you're hypervigilant, and in a higher fear state than usual. So traumatic memories are really one of the most impactful parts of going through a traumatic experience, in that you may re-experience memories or have flashbacks or memories that come up untriggered or triggered by other things, and that can be re-traumatizing. So having that memory that pulls to mind more quickly can be re-traumatizing to someone who's been through a traumatic event. And those traumatic memories can disrupt your normal thinking and your normal development when that experience creates some triggers in the environment. So that's where something that used to be a neutral kind of object in the environment starts to become a fear trigger, or a trauma trigger, that you start to feel fear in situations that normally wouldn't create fear. And some of the ways that we generalize our memories after a traumatic event, it starts to shape how we see the world. We start to see people as scary and dangerous. We can't trust ourselves or other people. If I let people close to me, they'll hurt me. I might have to get something before others take it: food, drugs, possessions. I might feel like I deserve to be hurt. I have to work really hard to protect myself. I have to get away. I have to run. These are sort of instincts that start to build up after somebody's been through a traumatic event, if they can't work through some of those traumatic memories. So when we talk about PTSD is one of the trauma-related diagnoses that someone can get. To be diagnosed with a post-traumatic stress disorder or PTSD, you have to have a traumatic event that has happened, or a traumatic situation. It could be acute or chronic, but there has to be a traumatic triggering event. And then you have to have all three of these kind of highlighted symptoms: intrusive thoughts or re-experiencing of that trauma, those traumatic memories coming back. Flashbacks is often what people call that. Avoidance or emotional numbing, sort of a desire to avoid certain situations or triggers, and also a desire to numb the feeling of fear that you experienced while the trauma was happening and afterward. And then hyperarousal in brain terms, meaning hypervigilance, your brain is on edge. You're in that fear state. You might start acting out or have disturbance in your functioning in some ways. So all three of those are key symptoms of PTSD, and they have to last for a significant period of time beyond the traumatic event. So if someone only has those symptoms for a short period of time, less than a month, they would instead be diagnosed with acute stress disorder, meaning you have stress and a trauma response, but it resolves itself within that month after the traumatic event. So if those symptoms are ongoing beyond that, that's when someone would be diagnosed with post-traumatic stress disorder. There are some other trauma-related diagnoses in our new DSM. They're diagnosed in children, and they are trauma-related as well. So a child who's diagnosed with reactive attachment disorder or disinhibited social engagement disorder, those are responses in children to traumatic events that impact how they attach to caregivers and how they might engage with people. So we're not going to talk too much about those today, but we're going to focus mostly on PTSD today. So for our substance use disorder clients, trauma and substance use disorder are linked in a lot of ways. I'll find my sheet so I can say the stat that's really compelling. Oh, it's not on this page. So up to 59% of young people with PTSD subsequently develop substance use problems, especially a strong relationship in girls or girls that have experienced trauma. Alcohol and drug use has been associated with greater PTSD symptoms up to 1 year after a disaster or a traumatic situation. And women who use drugs were found to have significantly higher PTSD symptom severity and were more likely to meet the criteria for a diagnosis of PTSD compared to people who did not use drugs. For us, in serving a high needs and high severity substance use disorder population, we have a really high incidence of trauma, and serving women as well. 95% of Wayside clients have experienced one or more forms of trauma within their lives. And of our clients at Wayside, 24% have a diagnosis of PTSD while they're with us, meaning the traumatic event has been more than a month ago, and during the time that they're with us, they have those symptoms of PTSD. So it's a significant impact on substance use clients, especially women, I believe. The co-occurrence rates, the rates of co-occurrence of PTSD and substance use disorders. So over a lifetime, a person has a 7.8% chance of developing PTSD or having a diagnosis of PTSD, and over 26% lifetime prevalence to have a substance use disorder. So you can see in the general population, more people are having substance use disorders than PTSD. It's a little bit more rare. But people with PTSD are 2 to 4 times more likely than people without PTSD to meet criteria for a substance use disorder. And in the population that we serve that are seeking treatment for substance use disorders, it's up to 14 times more likely to have those co-occurring diagnoses. And then between a third and half of people with a PTSD diagnosis also meet criteria for a substance use disorder. Most common is an alcohol use disorder. And so there's a couple theories or hypotheses about how the two are linked, how PTSD and substance use disorders are linked. And I don't present them to say that this explains everything about how they're linked, but there are some hypotheses out there about it. One is that there's self-medication, that if you have PTSD and traumatic memories and re-experiencing of a trauma, that you're more likely to abuse substances in order to self-medicate, do that emotional numbing that we saw as one of the symptoms of PTSD. So that would be a reason why there's a high co-occurrence of PTSD and substance use disorders, that people are self-medicating their PTSD with substances. That's one theory. That's one that we certainly hear a lot anecdotally from clients, that's how their substance use started or escalated after a traumatic situation. But there are some other hypotheses. One is called the high-risk hypothesis, and this is that people who have a lifestyle of substance use disorders are more likely to be in situations where they might experience trauma and then get diagnosed with PTSD. So that maybe it's the substance use disorder that happens first and puts people at higher risk for PTSD in a trauma situation. And then there's also a susceptibility hypothesis, which is that having increased anxiety and arousal because of a substance use disorder, because of having that diagnosis, might increase people's vulnerability to having PTSD after a traumatic experience happens. So for people who experience trauma, maybe people who already had substance use disorders and some other mental health concerns related to that are more likely to develop PTSD, while someone else might not develop PTSD after a trauma. And that is something that happens, that not everybody who goes through the same traumatic event is going to develop PTSD. And several people can have different traumatic experiences, and some develop PTSD and some do not. It has a lot to do with your sort of brain configuration and resilience going into that traumatic event. It has a lot to do with when you seek help and how you seek help after a traumatic event. And kind of what sense your brain can make out of that trauma, and whether or not you can sort of move forward, or if you get stuck in those symptoms and in that limbic system of your brain. So let's see. Oh, I went backwards. Here we go. Forward. So here are some of the symptoms that we see from people who have been through trauma that may or may not be diagnosed with PTSD, but these are some common symptoms after a traumatic event. Anxiety or worries about harm to themselves or food or stuff. There's been links between trauma and hoarding behavior, that people who have been through traumatic experiences might have a compulsion to keep things around them, both to protect themselves, but also this fear that something's going to be taken away from them, or that their living situation or their livelihood might be unpredictable. So that's the heightened stress response, heightened anxiety and worry. Destructive behavior against self and others, that memory and belief that gets in there, like I deserved what happened to me, or maybe others deserve to be punished for it. Those kinds of responses to trauma can lead to destructive behavior. Some learning difficulties and language delays can happen, especially if the trauma occurred early. That information we got about chronic trauma in childhood having a more pervasive effect, meaning the brain is still developing your learning capabilities and language development at those stages. So if you have trauma in early development, it might come across as more learning difficulties or language delays because it's impacted those areas of the brain. You might experience dissociation or emotional numbing. The feeling that's a protective response to trauma often is to check out, kind of not be present with what's happening and try to numb the feelings that are happening because of it. Somatization, meaning sometimes we have physical symptoms instead of psychological symptoms, and that's a really common experience, especially for people who don't have a lot of language around what's happening for them. They might complain about stomach aches, headaches, backaches. They might experience it as physical pain instead of emotional pain. And that doesn't mean that they're necessarily in denial. It just means that some people have access to that language and that understanding of emotional pain, and some people don't, and they see it as physical pain, which is, also a symptom in itself. Sleeping and eating problems, things like nightmares are really common. Insomnia are really common with PTSD and with trauma response. Hoarding, eating, overeating, or aversion to eating, often it impacts sort of our body functioning in those ways. Sleeping and eating problems can come up. It's more kind of internal things that we might not see. There's a lot of perceptual distortions that happen because of those brain changes about being impacted by trauma and having those parts of your brain, the rational, the frontal lobe is underacting and those emotional senses are overacting. And so there's less connection with reality, and there might be some distortion with how you see yourself, how you see others, and kind of the meaning that you make out of things. There might be impulsivity, which I like this definition of it, skipping from a stimulus to a response without kind of stopping to assess the meaning of what happened, kind of going 0 to 100 without any kind of medium ground, which are all really understandable responses if you think of that as a trauma reaction, that if in an uncontrollable situation, sometimes there's not time to assess what level of emotion do I need to go to, and so sort of acting without enough information or skipping right to a reaction. Increased incidence of depression and depressive disorders. Mood lability, meaning change in mood, very excessive highs and lows, particularly outbursts of anger and aggression, or you might hear people call this making mountains out of molehills, kind of having an outburst over something that seems really small. Again, it's sort of that not being able to make sense of cues or make rational sense of what's happening. And then hypervigilance is a hallmark symptom of trauma. That's hypervigilance, meaning you're kind of looking out for the next thing that might happen, or you're overly suspicious or paranoid, maybe people might say. But what that causes internally is increased heart rate, blood pressure, always in a state of alert, always on guard, which actually wears on your body quite a lot. People will say that feeling of hypervigilance is really exhausting because you're on high alert all the time. Oh, I went backwards again. Here we go. So trauma treatments, I'm going to talk a little bit about some of the evidence-based trauma treatments, and I wanted to talk a little bit about how they work first. So there's two sort of philosophies about treating trauma. One is bottom-up techniques and one is top-down techniques. So bottom-up techniques mean working through the body to change the brain. So rather than approaching something from a rational thought perspective, approaching it from the sense of building a sense of safety and control in the body and that will impact the brain through sort of deactivation of the amygdala, that fear center, and being able to strengthen and regulate that self-reflection, the insula cortex. So what that means, these are approaches like having sensory awareness, practicing mindfulness about what's happening in your body, what they call autogenic training. It's a mindfulness practice focusing on sensations in the body to achieve that deep relaxation. So that's trying to deactivate the amygdala without thinking. I'm deactivating my amygdala and not feeling fear. Is practicing that sense in your body, and that is as impactful as approaching it from a cognitive way. Breathing techniques, they stimulate the vagus nerve, which is your parasympathetic nervous system, which is your calming, kind of calm down system. So that's a really helpful way to engage in a calming strategy. Meditations, movement-based techniques like yoga and poses, especially those that are grounding, calming, and safety-focused poses. So those are ways of approaching someone who's been through trauma in a way that's not making them relive or re-experience their trauma rationally, which we'll talk about. Some of the approaches to trauma treatment are very cognitive focused, and these are the opposite of that. These are approaching from body changes and relaxation and leading to brain change. The top-down techniques are the ones that engage the mind through the thoughts, so strengthening that prefrontal cortex, the rational part of your brain, and that singular cortex that's able to manage your emotions and regulate yourself. So those are kind of what we might be more familiar with: cognitive restructuring techniques, cognitive behavioral therapy, ways of reliving things or working with memories to correct them and make sure that they're what actually happened and not what your emotional mind is telling you what has happened. And then focusing and concentration types of meditations are those that are kind of, they're doing that same relaxation, but from a point of, I'm thinking about relaxing and I'm thinking about what my brain is doing. So the trauma treatments that are out there are several, and some of them come from different sides of that bottom-up or top-down approach. One of the most well-researched is trauma-focused CBT, or cognitive behavioral therapy, and I think that that's the most well-researched because there's a free training, there's a lot of data collection, there's a lot of evidence out there for this treatment. It's really focused on childhood trauma, and I went through that training when I was employed in the school district working with children who had been through trauma, and it's a great resource and a great kind of way to understand trauma, especially childhood trauma, and work with that. So I do recommend checking that out. It's a free training. You get 10 CEUs for free through that website there, which again Lucia will send out after this. But that is really, cognitive behavioral therapy for trauma is really about making sure that you're able to relax your body and then thinking through the traumatic event in a different way. So changing how you're thinking about the traumatic event so that it's not such a re-triggering memory, that you can kind of make some sense out of what happened, make some sense out of what you might be generalizing that's not accurate, and trying to work on some of those, your response to triggers and things like that. So that is a top-down approach, that it's cognitive first. Hoping to change the trauma response from there. There's eye movement desensitization and reprocessing, EMDR, which we've heard a lot about. And that, to me, is a really unique one because I think it combines the top down and the bottom up. There's sort of a body component to it. And I'm going to let Andrea talk a little bit more about it when we get to our case, because she practices EMDR with clients and did with this particular client. So if you have questions about EMDR, she is absolutely the best person to talk about what it is. But it's really about, it starts with resourcing, kind of developing the client's abilities to regulate, and then goes into some processing of the trauma, but using some of the body cues and eye movements specifically. So to me, I like that approach because it combines those bottom-up and top-down approaches to trauma treatment. There's also somatic experiencing, which is very much a bottom-up. It's about experiencing what's happening in your body and working from that level to. You may never necessarily process the trauma that happened. You might just focus on the body experiencing. So that's a bottom-up approach. Narrative exposure therapy. I think I took prolonged exposure therapy off this list. PET, or prolonged exposure therapy, is sort of a classic trauma treatment. And I don't think I did this on purpose, but maybe subconsciously took it off the list because it's not really recommended for people in early recovery from substance use disorder, because it is a re-experiencing. You're exposed to the trauma triggers in a sort of controlled environment and with some help and support. But the point of it is to re-experience the trauma in a safe way. And so it's not recommended for people with substance use disorders unless they feel stable enough to do that re-experiencing. And it's also not recommended. It was developed for people who had war types of trauma, soldiers who had been through war types of trauma, where experiencing is a little different than someone maybe who had a sexual assault, where we wouldn't recommend that someone who went through a sexual assault be exposed to something like that or re-triggered in that way. So it's not, prolonged exposure therapy is not something that we do or recommend necessarily with our clients. If they're looking for that specifically, there is a lot of evidence out there for it because, again, it's used with soldiers. They've collected a lot of data on how helpful it is for those types of trauma. And it's not for everyone. Narrative exposure therapy is sort of a derivation of prolonged exposure therapy, where you do retell the tale of your trauma, but you make it into a narrative, and it takes sort of a narrative therapy approach where you're talking about the meaning that you made out of those experiences and maybe working through the meanings with a therapist. So again, that is a cognitive type of trauma treatment. Both prolonged exposure and narrative exposure therapy would be, I would say, top-down approaches to trauma treatment. Then there are some trauma support programs that I know that we use in our substance use disorder treatment programs. Seeking Safety and Trauma Exposure and Empowerment Models are two. They're more about building in a trauma-informed kind of support for people with trauma. It's not a treatment for trauma itself, but it's a way to support people with trauma in a group setting and in a group environment. And we'll talk a little bit about kind of the components of that. So those are really the trauma-specific therapies that are out there and that people might mention to you or be looking for when they've gone through a trauma. But I also want to say that there are a lot of ways that we as substance use disorder providers can provide a responsive environment for trauma that doesn't necessarily mean that we're providing specific therapy for the trauma. Generally, if somebody wants specific therapy for a trauma, we're going to refer them to a specialist or therapist who has some specialization in a trauma therapy. And there are things that we can kind of build into our residential environments or our treatment environments that can be responsive to the needs of people with trauma without necessarily treating that trauma. So these are some really important components of a trauma-informed environment or a trauma-informed treatment program. One is having staff nurture those trusting relationships. Being open and honest and authentic with clients really helps that person start to trust again. A lot of times people who have been through trauma are really mistrustful of others because of things that they've been through. So there's, the Adverse Childhood Experiences, or ACEs, questionnaire about childhood experiences that are traumatic. There's been some growing research saying that there's really healing power in having one healthy and supportive relationship throughout the rest of your life. If you've had some adverse childhood experiences, that's what really counteracts it, is having a caregiver or an adult or a supportive person in your life that you do learn to have a trusting relationship and a nurturing relationship. Having awareness and acknowledging trauma, so having awareness that people have been through trauma, if they have in your program, knowing that that's likely something that's happened if you're working with a substance use disorder program or clientele. So using what you know about the client to respond authentically if they want to talk about the trauma, not necessarily needing to know a lot about trauma, but to be able to acknowledge that what they experienced and how they're feeling is valid and is hard and is really a part of their story. So I think we'll talk a little bit more about that one. Creating safety is really important for people who have been through trauma. That's really what trauma is a feeling of unsafety for very good reason. Something traumatic happened that made you feel unsafe. So as much as we can incorporate safety into rules, guidelines, discipline, it gives clients the sense that safety is attainable. It is a goal that they can have for themselves, and that they can, that we're trying to keep them safe by having things like rules and guidelines. We want to be able to model a calm environment. So if we have trauma responses, or if we have trauma in our history, we need to do our own work so that we, when we show up to work, are not a further trigger for people with trauma, that we can, as much as possible, model a calm environment and let them know that that's possible. Self-regulation is a really important skill for us to be around people who have had trauma. Consistency, again, unpredictability is really a highlight of trauma. And so as much as we can make things predictable and consistent will help clients feel safe. Validating trauma experiences rather than minimizing the client's feelings or fears, not saying you shouldn't be scared of that because that happened a long time ago or that person's not here. More about the experience of the trauma for them and validating that. A lot of times people want to minimize or say things like, well, at least this didn't happen to you, or at least you're okay now. And that's a really kind of dismissive attitude toward trauma. So being able to validate those experiences. Using positive reinforcement and enhancing people's self-worth rather than punishment or negative reinforcement is really important for people with trauma. Recognizing our own feelings and fears or maybe lack of understanding about trauma so that we can better approach that. And then developing individualized care plans, meaning get to know the person so that you know what if there's been traumatic experiences and what the triggers might be and how we can help support them. And if we have a trauma-informed environment, but they're going to interact with lots of systems out there that are maybe not trauma-informed in their lives, child protection, the legal system, then as much as we can help them prepare themselves and build up their individual resilience and have that be as good, as positive an experience as possible when they have to go into systems that maybe aren't trauma-informed or trauma-responsive, that will help them as well. Ooh, backward, forward. Okay, we're going to do a case here. I'm going to read some of the facts about this case, and then I'm going to hand it over to Andrea Rowland, who's our mental health therapist who works with this client, and she's going to talk a little bit about the therapeutic work that they did around this client who had both PTSD and substance use disorder. So I will give you a little brief synopsis of this client with no protected health information in it. That's important for us to maintain confidentiality of our clients while we're on echo. So this is a 35-year-old woman who was in our family treatment program previously. She was there with methamphetamine and alcohol use disorders. She started to abuse marijuana and alcohol at age 14, and substance use was really prevalent in her family growing up. Being at Wayside in our family program was her second treatment episode in her life, so she had gone once before to a treatment program. She was diagnosed with PTSD, had that diagnosis previous to coming into Wayside. She was also diagnosed with bipolar II disorder and an unspecified anxiety diagnosis. The previous diagnosis had come with some scale scores. She had really high scores on a trauma symptom checklist, high scores on depression, anxiety, and a PTSD checklist. So it was a pretty accurate diagnosis that she had. She had 4 kids, ages 15, 6, 4, and 2, who were living several hours away with a foster family while she was at Wayside Family Treatment, and the 2 younger children were having visits with her while she was there. She had a voluntary child protection case following an incident where she left her younger children with the older child for several days and had some use. So she called for some support after that incident, and a voluntary case was opened up before she came to Wayside. Her trauma was really around some partner violence that she had experienced with 2 separate partners, but with a really significant abuse incident that had happened about 1.5 years before she came to treatment, that she was having constant triggers and memories, traumatic memories around, which Andrea can talk a little bit more about. So there was a significant incident of abuse that happened that had really triggered the PTSD diagnosis, but she had experienced a lot of abuse in 2 relationships that she was in. And she had had a history of suicidal ideation and some hospitalization for that, separate from her treatment episodes. So when she came to family treatment, requested EMDR. I'm told that she knew that was a trauma treatment that was out there, and she really requested to work on her trauma and to do some EMDR. So we referred her to Andrea Rowland, who I'm hoping is going to unmute herself and can talk a little bit about. Yeah, great. So Andrea, can you talk a little bit about the work you did with her around her PTSD and substance use?
Sure. When I first started meeting with this client, she was visibly, experiencing her trauma on a day-to-day basis. She was very fearful. She was tearful. She could not talk about things that had happened to her without breaking down in tears. I think the decreased and the low self-esteem, that thinking that what has happened to you or what has happened to her was her fault, that Jessie had talked about with as part of PTSD symptoms was very prevalent. Basically, what had happened with this woman is that her significant other, about a year and a half ago, assaulted her so badly that she almost died. And so she had, I guess we would say, complex PTSD from other events in her life, and this event is what kind of compounded everything else and really brought out those PTSD symptoms. So we did want to start with EMDR with her. However, the length of sobriety I think is extremely important when working with EMDR or using EMDR with clients, just for the fact that a lot of the times we don't know. Withdrawal symptoms can very much look like mental health symptoms, so we want to make sure that there's at least like 60 to 90 days of sobriety before we start this process. And also to make sure that the person is in a stable living environment. This client was going to be moving to a different residential facility where there's a possibility of her having a long-term living situation with their children. So we didn't actually start EMDR until after she moved out of family treatment. And she had, oh gosh, I want to say over 90 days of sobriety at that point. And basically with EMDR, which stands for eye movement desensitization and reprocessing, you're basically moving these memories from parts of the brain where they're stored where they shouldn't be, because they're continuously reactivating that stress cortisol, and then people have those symptoms of reliving the traumatic events, flashbacks, nightmares, those kinds of things. So basically what we're doing is we're moving those memories to a spot where they're supposed to be. So we're reprocessing them to an appropriate spot. And the way we do that is we move them from the nonverbal part of the brain, which is the right side, to the left side of the brain, which is the verbal side. And we do that with something called bilateral stimulation. And that can be done several ways. I'm kind of old school and I use my fingers, which is you have the client follow your fingers for a certain number of movements back and forth, depending on what phase you're in. Some therapists who do EMDR all the time use a light bar, and the client will follow the light back and forth. And then sometimes people are more tactile and they'll need to use something they're called like hand paddles or buzzers, and they will vibrate back and forth. Other people are more auditory, and they will wear headphones and it will beep from side to side. All of it is about activating both sides of the brain at one time. And then to reprocess these memories to a better location, or I guess where they're supposed to go. And we also do that with pairing it with things called positive resources. So before the process of the bilateral stimulation and reprocessing those things even starts, we make sure that the client has the coping skills and the things that they need to handle these things outside of session. So we're talking about creating a safe place, container exercises. Sometimes we teach clients thought field therapy or tapping as a way to, something that they can do in between those sessions if they are triggered, if their trauma is triggered. And basically, we create those things, and then depending on where the client wants to start, we can start at the worst memory, we can start at the first memory, or the most recent. And with this client, we started right away with that traumatic experience. And the cool thing about EMDR is that you don't necessarily have to go into detail when you're talking about your trauma, because we know that talking about or going in detail about things that have happened to us can be re-traumatizing. So that's one of those positive things about it, because we're noticing more about where they're feeling these things in their body and just having them notice that and move through the memory that way without having to put words to it. So we started with this client, we started with that memory, and I think we did about six actual sessions of EMDR, and we're kind of at the tail end of reprocessing that memory. And she has been very fortunate not to have any kind of side effects from the EMDR, where she's not getting triggered in between sessions. She's not having flashbacks. In fact, she does not completely remember or is not affected by the actual memories that we've already processed. She remembers things that happened before, and she remembers things that happened after. She doesn't remember exactly, you know, the things, the memories and parts of the memories that we've already processed. So she's actually receiving quite a bit of relief from her day-to-day symptoms of her PTSD. She's no longer having nightmares. Flashbacks are few and far between. She's able to use public transportation. She's able to be around new people. She no longer shakes when we're talking about the trauma. She no longer is tearful. She's, you know, and she's been reunified with her 2 youngest children. So she's really, really responded well. She's done an incredible amount of work in substance use treatment, you know, working on other things as well. But she's really been willing and dedicated to this process. And I think that's another reason why it's worked so well for her.
Awesome. Awesome. I'm going to pause there for questions, either for Andrea about EMDR or about that particular case, or about PTSD and substance use disorders generally. So any questions, you can either unmute yourself or type them in the chat, and Lucia will read them for us. Open it up. Andrea, maybe while people are thinking of their questions, I know they all are, could you say a little bit about, you know, you want to delay the start of EMDR until someone's really ready, or maybe has some length of sobriety for, you know, for this client it was 90 days. What kind of work might you do with that client in the meantime until they're ready, or how do you know when they're ready to start EMDR?
A lot of it has to do with supports in the community, like where they're living, who they have in their life, how are they on medication, are there other mental health symptoms being treated, are they having active mental health symptoms with other things, you know, and are they continuously being triggered by that trauma stimulus. Let's say, you know, if they want to process you know, abuse from a relationship. Well, if they're still in their relationship, then there's, you know, those kinds of things. So I'm hearing a lot of feedback. I'm not sure.
Yeah. I have a question.
Sure.
Can you hear me?
Yes. Let's share up.
Okay. Hey, Andrea, I'm wondering how, I know I think you said you didn't start her right away.
Mm-hmm.
With the therapy, yeah, but I was wondering how many sessions did you have and how long were those sessions?
The sessions are usually 60 minutes, sometimes longer, depending on where the client is in their processing. You know, if they're at a vital point, or they're experiencing a lot of, if they're really kind of in a spot where it's not safe to end it, you know, then we'll keep going. But, you know, depending on what kind of memory they're processing, or even, because you can use EMDR for other things, but with trauma, there's no set amount. You know, somebody could get through a trauma in 3 sessions, others it could be 24. It really depends.
Okay, depends on what she's experiencing, like you described her as, actually that process of her not continuing to experience that, or those symptoms that she, you know, presented were going away and gone. That's pretty amazing.
Mm-hmm.
Could you just one other thing? What type did you say? Did you use finger, right?
I use fingers. Yep.
Yeah. Okay. Attached with like the eye movement then, or?
I'm sorry, what was the beginning?
Did you used eye movement?
Yes, here. I'll show you. Hi.
You see me? You know, I can't see it, but I can get on and look at how that works from. I mean, I've had some experience, and I was just wondering, you know, from you, I've had some experience with the paddles, you know, with place that I've been before and stuff like that. So, okay. All right. Well, okay, great. Thank you.
Thanks, Carol. Andrea, will you show us, to us who can see you, kind of what it looks like?
So you can kind of see what you do is you sit with a client like ships passing in the night. So your knees are kind of offset. And depending on whatever, if the therapist is right-handed or left-handed, it doesn't really matter. But you're asking them to follow your fingers. So their eyes are going to be watching your hands moving back and forth. And depending on what part you are in the process, whether it's installation or it's the unfinished, whatever it is, they're going to follow your fingers for a certain period of time. It could be anywhere. If you're installing something like Safe Place, it's like a shorter period of time. It's like 50 to 20. If you're processing a memory, it can be anywhere from 25 to 35 passes. So if that makes any sense.
Yeah, it's really cool. It's a cool kind of way to do it. Any other questions or thoughts or experiences?
Is there anything in the chat?
Yeah, any questions at all about any of the different trauma treatments that were mentioned? I know a little bit about some of them.
Hi. Hi, I'm wondering if I could ask a question.
Yeah,
of course.
So I'm kind of curious, are there other PTSD treatments that are more effective and have higher efficacy than EMDR? And how are they different from other short-term cognitive behavioral type treatments?
Yeah, that's a good question. The person on the phone that we can see. So the question was kind of, are there other trauma treatments other than what we mentioned on those slides? Those were the main ones that were listed as kind of evidence-based practices. And really, the approach that somebody wants to use depends a little bit on the type of trauma that they've experienced, when in their development they experienced it. I mean, some people really want to do kind of cognitive types of therapy, and some people aren't ready for that or don't feel ready for that. And that depends a lot on what happened and where they're at maybe in their recovery from that. So I think that the short-term strategies are more along kind of the starting phase of a lot of those trauma treatments, which is the building up of your own resources and coping strategies for dealing with the triggers, dealing with flashbacks. Almost all of those trauma treatments start with a period of time where you're developing some coping strategies and relaxation skills, so that when triggered, you have some kind of way to calm yourself, to return to baseline. So that's probably the most common across programs.
My understanding is that's not true. My understanding is that treatments like prolonged exposure and cognitive processing therapy have a higher effectiveness rate, and they use a different mechanism to get at the trauma, and that it's really about the PTSD symptoms. Mm-hmm. So I'm just kind of curious about your thoughts in relation to that.
Yeah, I think I would agree with you that it depends, what approach works best does depend on the trauma and kind of where it is in the past, and what the individual feels ready to do as far as cognitive processing of the trauma or not. And so I don't disagree with that. I think that it does have I think there's a lot of more evidence for those cognitive based treatments because they're easy to gather evidence around, and some of the more bottom up or body based treatments are harder to gather evidence for, certainly, and so that's one of the issues with an evidence-based practice in general is it's designed to gather evidence, and it might not always capture all the different approaches.
I think the evidence would actually say that it doesn't matter what the trauma type is. It's really about the 20 symptoms and the treatment of the 20 symptoms. Mm-hmm. And so I'm kind of curious about your perspective on that. I mean, there's enough trauma to go around as long as it's a short-term evidence-based CBT approach. But I think that there are differences in opinion theoretically around trauma versus PTSD.
Sure. Yeah. I think that kind of what I was saying about the bottom-up versus top-down approaches those are two different philosophies of treating trauma. That some people might feel more drawn to a top-down cognitive approach, and some people might feel more drawn to a bottom-up approach, or sort of a somatic approach. And yeah, I think that people are drawn to different treatments for different reasons. And you're right that addressing the symptoms is really what everybody wants. That's what, they want to reduce the activation, the hypervigilance, and the fear. And so that's what I think it's common across a lot of those practices, is how do you deal with symptoms first, whether or not.
Well, because there's some pretty good research out there that shows that people with no trauma, people with trauma, and then people with PTSD, their cognitions are very different. So people with a history of trauma, no trauma, their cognitions around shame, blame, and negative cognitions about the world are very similar, whereas people with PTSD, those are very highly elevated. So that's where we get into the question of, are you treating trauma, are you treating PTSD? And so I think it's a valuable discussion to have as we're conceptualizing PTSD in general.
Mm-hmm. We're right at our closing time. Is there one more question that's pressing for someone? I think I've been seeing someone trying.
Carol.
Okay. Then I want to thank everyone for participating today. It's been a good conversation and good information. Be sure that we know if you need continuing education, we need to know who you are and how to contact you. So be sure to put something in the chat box really quickly here if we didn't identify you earlier. Our next session will be on June 20th. And as Jessie said, we're going to be looking at anxiety and substance use disorder. And we will not be meeting as an ECHO community in July. Everybody gets to take a little time off. And we are looking forward to coming back in August. You'll get all kinds of information about what's coming up. And I also want to share with you that if you enjoy this Zoom technology, we do a Friday Forum series of events once each month during the academic year, and we're going to be moving into a hybrid of both in-person and Zoom distance learning, so that if you are in a faraway place or have a tight schedule, you can still participate. And these are longer form, like events that are usually 2 to 3 hours long and take place on Friday mornings. So watch for that information as well. Have a wonderful day. Enjoy the sunshine, and we'll see you hopefully in a couple weeks.
Thanks, everybody.